Good morning, everybody. Martina O'Connor here, Hemovigilance Officer in GUH. So on the first slide, I'm going to talk to you about safe transfusion practice here. Galway Blood and Tissue Establishment is who you'll be liaising with if you're requesting blood and blood products or sending over samples. Just make sure that you contact 4422 or 4909 during working hours, but outside of working hours, you need to go through switch at 9. Okay, so first of all, we're just going to talk about transfusion triggers and patient blood management, and that's a big buzzword recently. And that's basically about reducing the amount of blood that we're given to patients and addressing inappropriate and unnecessary transfusion. So once upon a time, it was always give 2 units of blood, but now it's give 1 unit of blood. So routine transfusion is on a single unit basis. So we give 1 unit of blood, check the hemoglobin 15 minutes following transfusion and assess the patient, and they may not need that second unit of blood or any further transfusions. Because we need to keep in mind that there are risks of transfusion. So sometimes it's not always straightforward, and a patient may develop antibodies, they may develop a reaction, and also there's the human risk where a patient may receive the wrong unit of blood. And we'll talk about ways of preventing that later in the presentation. So in relation to the triggers for transfusion, as regards, what hemoglobin we generally would transfuse on, they are all available on the front page of the blood prescription transfusion record. So do familiarize yourself with that. Okay, so we'll go on to requesting blood and blood products. So in relation to medical patients, we generally comply with the triggers. But just to inform you, anemia isn't a reason for transfusion. Sometimes we do have to look into the background, and patients may have iron deficiency, anemia, folate deficiency, etc. And that's what needs to be treated as opposed to giving them a blood transfusion. For surgical patients, preoperatively, when we're cross-matching them, we need to adhere to the maximum blood ordering schedule. And that's the surgical blood ordering schedule. And that's available on Q-Pulse. And it basically dictates how many units of blood that we need for each surgical procedure. You starting off, you might think a hip replacement, for example, is a very big surgery, and you might need a few units of blood. So for example, a total hip replacement, we just group and hold those patients. So rarely would we be cross-matching any more than 2 units of blood, for example, for a procedure. So if you feel a patient is going to require blood, obviously you're going to be cross-matching them, but you need to inform the patient. And we've done studies recently, and patients feel that they're not being informed about their blood transfusion, that they haven't been told by their doctors that they require a blood transfusion. So that needs to happen. You need to explain the risks and benefits of the transfusion and record that in the medical notes. And you also need to offer them the information leaflet. For a certain group of patients, for example, hematology patients and nephrology patients, so those of you working in those disciplines, some of those patients will require irradiated blood or CMV negative blood. So irradiation happens, actually, we have an irradiator here in the blood establishment, and it basically blasts all the T-cell lymphocytes out of the blood and prevents the patients developing graft versus host disease following their transplants. Okay, so in relation to the samples, the group and hold and a group and cross match, they're exactly the same thing. They establish the blood group of the patient, whether they're rhesus positive or rhesus negative, and whether they have any antibodies or not. And a sample is valid for 72 hours. So if you're requesting red blood cells, you need to have a valid sample within the last 72 hours. And if you're cross-matching, so listen carefully to this, if you're cross-matching a patient, so if the patient requires blood, we will need a second sample, but we may have that sample on a historical record. So don't automatically take 2 samples, and that's what's happening. Doctors are taking 2 samples from all patients at the moment. There's no need to take a second sample unless the blood bank will, generally they will contact you to say that you need a second sample if you're cross-matching, if we don't have a historical sample on the laboratory information system. So this is, if you have to take a sample, it has to be taken at a separate time to the one you're currently taking. So they need to be 15 minutes at least apart. And please do not take them at the same time and just change the timing on the forms or on the tubes. That is very dangerous. Okay, so in relation to labeling of the request form and the sample, if there's any little thing wrong with the sample or the form when it comes to the blood bank, it will be rejected. So the zero tolerance in the blood establishment in relation to errors on the form or on the sample. So we have the blood track devices now, and they must be used for labeling blood bank samples, except in certain circumstances. For example, if the devices certainly aren't working, well then, you know, but you do need to investigate that. Just say, oh, it didn't work for me, so I'm going to handwrite it. You know, that's not obviously good enough. So when you're taking a sample, group and hold or a group and cross match, you have to have all your ducks in a row when you're going to the patient. You don't go in with a tube and take a sample and come out and start labeling a form retrospectively. So you take with you your blood track devices, your request form, and your tube. So it's a pink EDTA, 6 ml for an adult, 4 ml for a pediatric. You have your addressograph label is acceptable on the request form here in GUH. So make sure you also put the location and the consultant that you write it onto the form and the reason for transfusion, and tell us, you know, a background if you're aware of the patient's hemoglobin, etc. So you take that in with you to the patient. And the two big no-nos in blood sampling is never pre-label tubes before you take the sample, and always label at the bedside. So when you go to the patient, you ask the patient to confirm, as opposed to telling them their details. You ask them to confirm their first name, their surname, and their date of birth. You confirm that with what's on their ID band and on their request form. And you also check the expiry date on the tube before you take the sample. So you proceed to take the sample, try to get as much blood into the tube as possible, and then when you have the blood in the tube, then you label the sample. So make sure that when you've taken your sample that you haven't taken it from a line where the IV fluids are infusing, and that you're aware, you know, that the patient does require a cross match. If it is a cross match you're taking, you've checked their current hemoglobin levels. And you label it then with the blood track device. So you scan your own swipe card. So never share your swipe cards. Scan your swipe card, scan the patient's ID band, and then you scan the printer, and a little label will be generated, and that will go onto the tube. Okay, so you make sure all of that is corresponding, all the details, and you direct the form and the tube to the blood bank laboratory immediately. And if it's an urgent sample, you inform the blood bank before you send it. And if it's urgent as well, as opposed to pushing it in the chute, you ring a porter to take it over. Okay, and if your patient is going in for surgery, make sure that the sample is processed before the patient goes for the surgery. In relation to taking the samples, just a little note on the hospital ID band. If the patient's hospital ID band is cut off, make sure that it's replaced immediately. Never take a sample from a patient who has no ID band. Okay, so onto the prescription of the blood components to adult and pediatric patients. And just if you could familiarize yourself, it's a 16-page document. On the second page is the prescription. So you prescribe legibly on a unit-by-unit basis with black pen. And it's only in a massive transfusion setting where you're giving a lot of blood to the patient, where you can then write red cells, 20 units, and all of the other products. So when you're prescribing Generally, red cells are given over 2.5 to 4 hours, but you have to exercise caution if you're transfusing a patient who has a risk of overload, like somebody with congestive cardiac failure or whatever heart disease. So then you may sometimes go outside of the 4 hours, possibly 5 hours, but this needs to be recorded in the medical notes and the reason why you're doing it. So platelets then are generally over 30 minutes and plasma also over 30 minutes. In relation to the pediatrics, it's slightly different. You won't be giving them one full unit of blood. So those of you that are going working in pediatrics, I will probably be able to speak to you at some point separately. But the formula for calculating the volume of blood to pediatrics is, so for example, if a child has a hemoglobin of 8 and you want to bring it up to 10, it's 10 minus 8 is 2, multiply by 3 is 6, multiply by the body weight. So for example, if the child is 20 kilograms, it's 6 multiplied by 20, which is 120 mLs. So you need to be very accurate when you're calculating that. And you put the exact volume of mils on the request form before you send it over to the blood bank. And for those working in pediatrics as well, a lot of our patients there are shared care with Crumlin. So they're oncology hematology patients. So we'll be complying with the shared care policy, which is available over in the pediatric unit. So if you're involved as doctors in the administration of blood components, and you will at some stage, we'll talk about later one or two of the products that you will be given, but you know, you may have a hemophiliac and you may have to give them some of their factors, and they're all blood products that come from the blood bank or whatever the product is. It must be prescribed on the blood prescription document, not in a drug chart. And that mistake often happens. You know, you think this is a drug, but it may be, if it's a blood product, it needs to go into the blood prescription document, the same place as you prescribe your red cells and your platelets, etc. And if you're involved in the administration of it, as I said, which you may be, always get a nurse involved, because the nurse is very aware of the document and the prescription section of it, and she'll be telling you exactly where to prescribe it. And also traceability is so important. So every product that we give to a patient, we need to have full traceability of it. So there'll be a little label that'll come off the product, and she'll help you put it into the patient's notes, and you'll have to sign that. And also there's another separate label that tears off the product, and you will be signing that. You'll be printing your name on that, and she'll be putting it in an area where it's taken back to the blood bank. And we have to keep all of those documents for 30 years now to comply with the European directive and full traceability. So if you're involved in administering any of those products, and if, for example, they don't need them, that you request 6 products and they only need 4 albumin, we'll say, for example, well, then make sure that you return them immediately, because blood and blood products it's very precious and expensive. It's 295 euros now for a unit of blood, and some of the other products are a lot more expensive. For those of you working in obstetrics, anti-D is one of the products that you will be requesting and prescribing a lot. The midwife then will generally administer it. So the product that we're using, and as you know, you give anti-D immunoglobulin only to rhesus negative women who have a sensitizing event antenatally, or who have deliver a rhesus positive baby, then they need to receive it postnatally. So a sensitizing event is basically where there's you know, a risk of the transplacental bleed. So this may occur at any stage during pregnancy. So for those less than 12 weeks, if there's any intervention to evacuate the uterus, for example, for a miscarriage or whatever, medical or surgical intervention, anti-D will be required. And for those greater than 12 weeks, any trauma at all, a seatbelt injury, any intrauterine procedure, they will require anti-D post 12 weeks. And we're also given the routine antenatal anti-D prophylaxis. We're given that at 32 weeks. And again, as I said earlier, postnatally, we'll be giving it to women who have rhesus positive babies. And if, for example, the Rofalac is the product we use, it's 1,500 international units. It covers 12 mLs of a bleed. If you suspect that the bleed is a bigger one, you will have to do Clyhor testing. You'll send off a sample in a purple tube, send it to the hematology department, and they will estimate what the fetal maternal hemorrhage is. So how many basically fetal blood cells are in mum's circulation. And the mother may also need additional anti-D then. And if it is, she'll require it intravenously, whereas normally one dose is given intramuscularly. Okay, so just the last word on NTD. It is the doctor's responsibility to ensure that the woman's blood group is checked, the official blood group, and if it's postnatally, that the baby's blood group is checked prior to requesting and prescribing NTD. Okay, so just a slide here on warfarin reversal, because at some stage you'll probably come across this. And as you know, warfarin isn't the product now that's given to all of those patients who require it for one reason or another. They may be given one of the NOACs, apixaban, rivaroxaban, those sort of drugs. But we'll just talk about the warfarin reversal first. So generally, if it's just a mild bleed that the patient presents with, the doctor would stop the warfarin, they give them IV vitamin K, and they may be able to restart on the warfarin again. But if a patient comes in, and oftentimes they do come into ED, and they come in with a suspected cerebral bleed or a GI bleed, well, the warfarin needs to be stopped immediately. They need to be given IV vitamin K, 10 milligrams. And you'll be consulting your hematologist and discussing it with them. And the patient will probably need, depending on their INR, but they will probably need a prothrombin complex concentrate. And Octaplex is the product we give. It contains factors 2, 7, 9, 10, protein S and protein C. So for example, if their INR is 3, they will get 25 international units per kilogram. So you have to calculate the dose before you send the request over to the blood bank for the Octaplex. And the big thing with those products is you have to give it as quick as possible. We did an audit in 2020, and 33% of our patients received only 33% of our patients received the Octaplex to reverse the warfarin within 60 minutes of request. And 60 minutes is the time that's recommended by the Serious Hazards of Transfusion in the UK for it to be effective. So it needs to be given ASAP. And you would obviously then check the INR post-transfusion and again at later stages. Okay, so we just, this is one of the last slides now, and we're just going to talk about the management of adverse reactions. So patients can get various different types of reactions. I'm not going to go through all of them, but for example, you know, a patient can get, there's quite serious ones like the TRALI, the transfusion-related acute lung injury. There can be viruses associated with transfusion of blood, but the most common ones that we see every day are the febrile type reactions. Okay, so if you get a call from a nurse, and what I forgot to say here is we must try and avoid nighttime transfusion, because you're on your own at night and you don't want to be getting a call in the middle of the night to say that a patient has a reaction to blood. So we encourage not to transfuse at nighttime unless it's urgent, obviously. So in relation to the febrile transfusions, patient's temperature is allowed to rise 1.5 degrees Celsius before you stop the blood. Okay, not at 1.2 or 1.3 as sometimes can happen. So if you get a call, if it's above 1.5, you advise to stop the unit of blood. You can give paracetamol 1 gram intravenously if we'll say it's less than that, and slow the transfusion. So if it just goes up 1 degree, you could give the 1.5 and stop it and continue it, slow it and continue it. But if it's the 1.5, you stop and you recheck that the identity of the patient, obviously that the patient is up on the correct blood, because we have to outrule an ABO incompatibility. and you'd maintain an open intravenous line. So the bloods you would do is you would carry out blood cultures on the patient who had ruled that the patient isn't septic, because sometimes that's oftentimes the reason behind it. And you would do another repeat cross match. So you would do cultures and you would repeat a cross match. You ring the blood bank, you request a transfusion reaction pack that will give you most of the details that you require, but it's just what I'm telling you now, the cultures and the repeat cross match. And they are sent to the blood bank along with the implicated unit of blood that the patient has just got or partially got. And the blood bank then will culture the unit of blood to outrule contamination of the unit of blood. So we will be liaising with you on the blood bank after that, and we may require further bloods. For example, you know, you may have to do haptoglobin levels, further coagulation studies, etc. But do liaise with the hematology team as well, and you will be able to get more advice from them. And so additional bloods, for example, if we're querying that there's a degree of hemolysis there, for example, we will be requesting bilirubin levels, etc. There's other reactions, so they're the febrile type reactions, which are possibly the most common. The other type of reactions that are common are the allergic type reactions, you know, the mild urticaria and pruritus. If that's the case and the patient is, you know, can tolerate it, we generally slow the transfusion down, and oftentimes they can tolerate the transfusion and that it doesn't progress. But if the symptoms worsen or if they persist, you need to discontinue the transfusion. So again, you would assess the patient, contact the blood bank, you'll get your transfusion reaction pack over, and you'd carry out the IgA and the IgE levels and the tryptase levels. It may be a severe anaphylactic type reaction, and they can be quite frightening. You know, they can have serious respiratory symptoms, GI symptoms, in addition to the rashes and all of that. So you would have to stop the blood immediately, administer hydrocortisone and an antihistamine. You may have to give adrenaline in severe circumstances. And you obviously have to investigate, liaise with hematology and liaise with ourselves. Like I spoke about before, those patients at risk of transfusion-associated circulatory overload, there's nothing stopping you from maybe perhaps giving them a small little bit of a diuretic before their transfusion. But if anybody develops any signs of overload during a transfusion, and they could be dyspnea, cyanosis, tachycardia, pulmonary edema, etc., you discontinue the transfusion straight away, and you'd investigate it. The patient may have to have a chest X-ray, and they may also the BNP levels, the pro-BNP levels are very beneficial also. So, but you need to get a sample that you've taken pre and get them to do the BNP levels on that, and then take another sample and compare them. And troponin levels may also be helpful in those circumstances. So in those, in relation to any of those reactions, make sure that you record everything in the patient's medical notes, and that, as I said, you discuss with your senior members on the team and also the hematology team. Okay, so just the last slide here, I'm just going to talk briefly about the management of a massive hemorrhage. And we have the Code Red protocol here in place in GUH. And if you suspect that a patient is having a big bleed and will require more than 1 or 2 units of blood, the Code Red protocol will be activated. So 4306 24/7 is the number you would activate this on. And there's the process flow chart there. I'm not going to go through it in detail now, but if these situations are managed properly and coordinated properly, they will generally run smoothly. But just a few things to bear in mind is the first drug you would give a patient if a patient is bleeding is tranexamic acid, 1 gram intravenously. And if the patient hasn't been cross-matched, there's emergency ONEG available for the patient. But the first thing you would do is get a cross-match sample and send it over to the blood bank. and get the ball rolling. And again, I cannot emphasize enough, and sometimes we do experience this, is when we go to a code red event and cold blood is being pushed into patients. You know, you need to warm the blood in those situations. You need to be doing regular FBCs and coags. And our protocol at the moment, but this is likely to change certainly in the next 12 months when we're having a national protocol, is 6 units of blood, and then we have to come in with coagulation factors, and we find those in the plasma. So 4 plasma, which will have to be thawed, and it'll take 20 minutes. So the blood, the plasma, fibrinogen 4 grams, and platelets, and that's repeated then if the patient continues to bleed. So I'm not going to say any more on that. So thanks for listening to me, and just back to the basics: patient safety, identification. They're the sort of things where we seem to go wrong most. And so identify your patient always before taking a blood sample, and do it in the correct sequence. Thank you. Bye-bye.